This short vlog is a refresher, taking you back to what you learned on the prescribing course. It highlights the skills, techniques and approach needed to take a full history from the patient, particularly important where there is multimorbidity, as set out in the related NICE guideline. Whether you're gaining this information from the notes, which you check with the patient, or direct from the patient, or from an appropriate third party, without gathering this information, the patient may receive suboptimal, unnecessary, or even inappropriate medicines. We cover 3 areas, taking as read that the prescribing complaint has been thoroughly assessed and confirmed. Firstly, taking a full medical history. Secondly, taking a full medicines history. And thirdly, a brief discussion on how to appropriately involve the patient in order that together you can make a plan. These 3 areas are part of the overall history-taking process, which is shown here. There are 4 NICE guidelines that are specifically important here. The NICE guideline on shared decision-making, the NICE guideline on medicines adherence, the NICE guideline on multimorbidity, and the NICE guideline on medicines optimisation. Firstly, let's look at the key components to taking a full medical history. So for this we need to learn about any previous illnesses, hospital admissions, investigations, treatments and surgery, plus any ongoing episodes of care. We also need to explore the mental health history, bearing in mind this may have an impact on how we gather information about physical health. Or if you're a mental health practitioner, then physical health is equally important. We need to look at what long-term conditions does the patient have and how are these being treated? Who manages these long-term conditions? Is the patient seeing various healthcare professionals for different treatments? Does the patient have a care coordinator? Does the patient have a care plan or specific treatment or self-management plan? For example, an asthma care plan. Is the patient adherent to current and past treatments? What are the risk factors such as alcohol, smoking, obesity, recreational drug use, etc.? All these areas may be influenced by the patient's health beliefs. We also need to look at what the patient's ethnicity is, as this is a factor in treatment, for example the use of anti-epileptics in people of Asian origin or sickle cell disease in Afro-Caribbean people. That's a pretty big list. How you obtain this will be influenced by what information you already have, the service you work in, the time allocated for the appointment, including any preparation and housekeeping time, and the physical environment in which you are holding the appointment, plus by the patient's social situation, rural or social isolation, financial situation, family responsibilities, communication and language barriers, mental capacity, and basically how much the patient trusts you. So in order to approach this history taking, you need to do some form of top to toe assessment. It may be that you actually do a body scan with the patient from head to toe, asking specifically, do you have any headaches? Do you have any problems with speech? Do you have any problems with breathing, circulation, joints, movement, etc.? It may be that the patient finds some things difficult to talk about, and there may even be underlying safeguarding issues. The cues for this are often non-verbal. Also, when it comes to long-term conditions, if something is under control, such as blood pressure, the patient may even forget to mention it. This is something we've probably all done at some stage in some situations. So another way to cover this is to actually mention long-term conditions by name, maybe using non-medical names, and go through a list. For example, you could use the mnemonics such as MJ threads to do this. Secondly, let's look at what we need to cover to take a full medication history. As you'll know from the prescribing course, it is vital here that you have confirmed whether the patient has allergies or sensitivities, or has ever had an adverse reaction to a medicine. Although this is a critical area, allergies and sensitivities and adverse reactions are not consistently recorded across services. Also, how do you record allergies that are confirmed and patient-claimed allergies, i.e. things that you've been told about but not seen? At this point, it's important to consider allergies, sensitivities, and in particular, adverse reactions, or ADRs. A UK study in 2018 showed that avoidable adverse drug reactions cause around 712 deaths per year. That's avoidable adverse drug reactions. A sobering thought. Whether you're a prescriber or not, as a member of a clinical team, we all have the responsibility to help prevent avoidable adverse drug reactions by picking up red flags and ensuring the documentation is up to date and raising any concerns with the multidisciplinary team. The need for openness and accountability is a thread that runs throughout all of these short presentations. So if a patient is sensitive or allergic to something, it's important to establish what happens as a result of this allergy or sensitivity, how severe it is, and what treatment was given, including what was the outcome of the treatment. With adverse reactions, we need to establish what was the exact nature of the reaction. What was the cause of the ADR? Was it definitively established? What treatment was needed? And for the result of treatment, was the patient given an EpiPen? Were they referred to an allergy specialist, etc.? Are there medicines, excipients, combinations of medicines that the patient must not have? And are there any specific dietary red flags? Finally, are these fully recorded in the patient's medical records? These are vital considerations and especially important if the patient lacks capacity. An important case which highlights these issues and the need for multidisciplinary working, accountability, communication, mental capacity assessments, the consent process, and the best interest decision-making process, making reasonable adjustments, identification of and actions around red flags, involving patients and their carers or families, prescribing competency and prescribing governance, and measures to ensure safe practice, is that of Oliver McGowan. You'll find a link to a presentation on this in the comments section. As you also know, it's important to be able to list all prescribed medicines, including, as required, PRN medicines, with full details including what they were prescribed for and recently prescribed medicines that have been stopped, including why they were stopped. This includes over-the-counter medicines, internet-sourced medicines, medicines the patient may have borrowed from somebody else, and any recreational drugs. Other areas to consider include asking if a patient is taking any cannabis-derived medicines for pain. Sometimes patients may forget medicines, such as inhalers, eye drops, patches or creams, so you may need to specifically ask about these. Also, an increasing number of people have medicines prescribed privately, so again, a specific question on this may be needed. Then there's things like food supplements, vitamins, herbal remedies, homeopathic remedies, complementary therapies. As well as this, the patient's lifestyle, their posture, the amount of exercise they take, their diet and the amount of fluids are all factors to be considered. Fluids are particularly important consideration if the patient is taking a medicine that needs a constant blood level, such as lithium. This level could fluctuate in hot weather. That's a pretty big list. And part of the art of taking a history also includes finding out about adherence and the patient's beliefs about medicines and what their understanding is of what the medicine has been prescribed for. So finally, how do we make sure the patient is fully part of this process, is open with us, and owns any subsequent decisions and plans? In the NICE guideline on shared decision making, the authors suggest asking patients questions such as, have you missed any doses recently? Have you missed any doses in the past week? And also to find out more, especially around practicalities and possibly cost, you could ask, do you have any difficulties getting hold of your medicines? These questions are less confrontational than just asking directly, do you take it or not? I'm sure you will have ways of approaching adherence and building trust with patients which you're able to share with your teams. I hope you find this useful and it provides materials for discussion and reflection. These, of course, can be used in your appraisals, in peer reviews and for revalidation. You can find a template for reflection here.